So number one reason and most important reason is the decrease in the blood pressure or hypotension. So this is one thing which you will definitely find in your patients. If you start 100 patients on ARNI, there will be around, I will feel 20-25% patients which will experience hypotension. And we can do a lot of things because once we start patients on ARNI, they will definitely experience much better clinical symptoms. They will have less congestions. So in most of our patients, we are able to down titrate the diuretics. And once we are able to down titrate the diuretics, they are mostly able to tolerate the doses of ARNI. So whenever we escalate the doses of ARNI, we definitely go down on the diuretic dose slowly. And that definitely helps them. So the most important factor is definitely hypotension. Other side effects with ARNI like hyperkalaemia or angioedema, they are very, very rarely seen, if not ever in our clinical practice. Definitely in renal disease patients, we should be more cautious, and there can be some patients who develop hyperkalaemia, and those can be one of the reasons of not achieving a target dose. Very rarely patients can have angioedema or other side effects like irritable cough or GI symptoms. In our practice, hardly less than 1% of patients we had to stop ARNI due to GI symptoms or cough. So very, very rare in our clinical practice. And even if we are not able to reach the target dose, even if I am able to reach, I will not even say 100 milligram BD, which I am able to achieve in most of my patients, that is around 50% of my patients. Even if I am able to achieve a dose of 50 milligram twice daily, it gives a very, very good clinical response to my patients. Most of our patients are at least on 100 milligram twice daily, and it gives a very, very good clinical response to the patient as compared to the previous therapy. They come at least NYHA class 1 or 2 lesser to us when they come even as early as 2 weeks after starting ARNI. And mortality benefits, we all know that it has. So these are our recommendations. Reason for failure, we know. We have discussed that symptomatic hypotension we can see in this red. That is the most important reason. Sometimes hyperkalemia, sometimes GI symptoms, sometimes worsening in the renal function. So these can be some of the reasons that we are not able to achieve the full target dose of 200 milligram twice daily. So participants taking a lower than target dose, they also had a lower risk of primary event compared with those having lower than target doses of enalapril. So we can look at the forest chart here, and clearly nothing in favor of enalapril. Everything is favor of sacubitril valsartan, even in those patients who did not achieve the recommended dose of 200 milligram per day. So is